Hello, everyone, and welcome to today's webinar, The Diagnosis Matters, Elevating the Standard of Care for Women Impacted by Vaginitis and Vaginosis, presented by Dr. Karissa Culbreath. I'm Christy Jewell of Laboratories, and I'll be your moderator for today's event. Today's educational web seminar is presented by Laboratories and brought to you by BD. BD is a global medical technology company that is advancing the world of health by improving medical discovery, diagnostics, and the delivery of care. To learn more about our sponsor, please visit moleculardiagnostics.bd.com. Now, before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. Now, if you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of your presentation window, or just let us know you're having a problem by using the Ask a Question box. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I would now like to present to you today's speaker, Dr. Karissa Culbreath, Scientific Director of Infectious Diseases, Tricore Reference Laboratories, and Assistant Professor of Pathology, University of New Mexico Health Sciences Center. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Culbreath, you may now begin your presentation.
Hello, everyone. I'm very pleased to be able to bring you the presentation today, The Diagnosis Matters, Elevating the Standard of Care for Women Impacted by Vaginitis and Vaginosis. For today's objectives, we're going to describe the complexities and challenges of diagnosing vaginitis and vaginosis, and these complexities are really due to significant symptom overlap, co-infection and co-detection of multiple organisms and pathogens that may be associated with vaginitis, and looking at an update of the current guidelines as they apply to the challenges related to diagnostics. I will also be able to describe a few of the diagnostic testing options that are currently available, along with the benefits and limitations of each of these options, and then looking at some of the emerging methodologies for molecular testing and how this will impact diagnostics in the future based on a study that has been performed in my laboratory. But first, a bit about the vaginal microbiome, and really I add then a plural there, the vaginal microbiomes, because we're starting to learn much more about the various compositions of the vaginal microbiome. But so unique to the vaginal microbiome, we find that a single genus, which is called Lactobacillus, is predominated in this microbiome space. And this is unique because in many of the other body systems that have microbiomes, the skin microbiome, the oral mucosa, the gut mucosa, there's usually a broader composition of organisms that are found at various levels and in various individuals in those body sites. But what we find with the vaginal microbiome is that really across people and across the population, we find that it's predominated by Lactobacillus. And this is likely because Lactobacillus produces lactic acid that has the significant impact of reducing the vaginal pH. And this reduction of the vaginal pH is important for maintaining a normal, healthy vaginal flora. But even within the composition of the vaginal microbiome with Lactobacillus, multiple what's been described as community state types have been described among the population. And these different community state types may have different compositions within them, but they are typically dominated by one or more species of lactobacillus. And so what we find is that although there seems to be some uniformity with the vaginal microbiome being predominated by lactobacillus, even within that, we do find some diversity with the different species of lactobacillus that may be present, or the different organisms that are also associated within those normal healthy microbiomes in the vaginal tract. What we also find is that the microbiome is not just a static, the vaginal microbiome is not a static entity. And so in this study that looked at the microbiomes of several women, a large population of women over time, what was found is that the microbiome, though typically dominated by just a few species, can have some fluctuations and changes over time. So that it is not just a static entity, but the organisms represented in the microbiome can change. And these, the factors that would influence the changes in the vaginal microbiome include things like sexual activity, menstruation that happen in a continuous manner, but then also episodic factors like pregnancy or the initiation or completion of menopause can have significant changes on the overall composition of the vaginal microbiome. So it's not just this one static entity, but there's many changes that can occur at any given period in a normal, healthy vaginal microbiome. And so when we take this all together to try to understand how does the vaginal microbiome impact human health and disease, what has been described is that when there is a higher amount of community stability, so that is that the microbiome is as normal, so you could say as possible, that is heavily predominated by lactobacillus with some other supporting organisms that are available, then the normal vaginal microbiome is healthy and is able to support a more healthy state. As the diversity of that community begins to increase and the lactobacillus loses its predominance in the microbiome, as you can see on the lower part of this slide, this change in the microbiome can create a space where there may be a more likelihood that disease states could occur. So these disease states including vaginitis and vaginosis, but not only that, we have seen that as the community diversity increases and there's that loss of the lactobacillus dominance in the microbiome, there's increased risk for transmission of sexually transmitted infections, increased risk of transmission of HIV, and then we also see the presence of organisms normally associated with vaginitis and vaginosis, such as Trichomonas and other infections. So this vaginal microbiome overall is a significant impact on the vaginal health in a patient. And so if we go to the next slide, this was a very interesting study that looked at the vaginal community. And so I'm going to walk you through this slide because it's a little bit complicated, but it does highlight some very interesting factors of how lactobacillus does play this important role and this important relationship with other organisms that may be found in the vaginal space. So what you can see is that there are multiple organisms that are listed on the lower and on the right-hand side of this graph. And what we see is the relationship of these organisms to one another, and then multiple states of the vaginal microbiome. And so what this first lets us know is that lactobacillus, as was described earlier, are usually not found in the presence of other genera. So when we see lactobacillus, as you can see on the lower side of the slide, and then you can see on the right-hand side of the slide that lactobacillus genera goes, only up the first quarter or so of the organisms listed there. The green means that they're found associated with one another, so that these lactobacillus are generally found together, and they're not usually found in the presence of other genera. What we also see is if you look just to the left of the green box, there is a categorization of the Nugent score, which is a classification of the normal microbiome in a way that we can diagnose bacterial vaginosis. And so we see that these lower Nugent scores, which means that the vaginal microflora is more normal, is more associated with lactobacillus and a predominance of lactobacillus, which is exactly what we would expect. But then we also see that these other organisms, so if we see this red box that's over to the right of the slide, these are many other organisms that are listed here. These other organisms, these are usually not associated with lactobacillus, and they are associated with having the highest Nugent score, whereas the lactobacillus species that we see are usually associated with lower Nugent score. Again, highlighting the fact that lactobacillus predominating in the vaginal microflora are usually associated with a more normal and healthy microbiome, but there's a whole variety of other organisms that are not associated with lactobacillus, but are usually associated with higher Nugent scores, and thus opportunity for more disease that may be present, including vaginitis, vaginosis, but then also a higher risk for acquisition, potentially of other pathogens in the vaginal tract. And so, taking all of this together, we see that diagnosis of vaginitis and vaginosis is not just a single pathogen challenge. It's not just a question of, is there one thing that may or may not cause disease? We're also looking at this protective factor that lactobacillus display as it relates to the normal, healthy vaginal tract. And so we have various methods that we can use to try to detect the organisms associated with vaginitis, but they also have significant challenges that we'll explore further in the next few slides. So vaginitis itself, so the disease state that we'll be discussing for the remainder of the talk, is the most common gynecologic diagnosis that is seen in primary care. And so if you look at the relative proportion of individuals that would experience disease, we see that bacterial vaginosis is the most common, with up to 50% of women presenting with bacterial vaginosis, and then 20 to 25% prevalence in the population with vulvovaginal candidiasis, or VVC. A slightly smaller proportion of patients with a prevalence of Trichomonas, and then there's also non-infectious vaginitis, that is vaginal symptoms that are not necessarily associated with an infectious pathogen, and that's at a lower percentage at 5%. These all are characterized by common symptoms, though they may be slightly more prevalent in one infection or the other, but the symptoms have significant overlap, and that is patients presenting with increased or thickened discharge, with odor, itching, and burning, and then general vaginal and urinary tract discomfort. So bacterial vaginosis typically presents with what's described as a fishy odor, a thin and homogeneous discharge, and then generalized pelvic discomfort. Important to the diagnostic considerations for bacterial vaginosis, this is not necessarily just a disease causing the discomfort. There are significant other sequelae associated with bacterial vaginosis, which include preterm delivery and premature rupture of membranes in pregnant patients experiencing bacterial vaginosis. There's been many studies that have described an increased risk of the acquisition of sexually transmitted infections, as well as the increased risk of acquisition of HIV, and then also higher amounts of shedding of the HIV virus in the vaginal space for patients who are both HIV positive and positive for BV. There's higher loads of HIV found in the vaginal secretions. It's also associated with the development of pelvic inflammatory disease. And so what's important to recognize is that there is a specific and unique treatment for bacterial vaginosis that's different for the treatment, for instance, of the other causes of vaginitis, and that is metronidazole. That does have a pretty good cure rate, but we do see that there's a fairly high rate of recurrence that may be due to reinfection or relapse of this vaginal dysbiosis that can occur in up to 58% of patients. And so BV, though it may be considered as just maybe a low-risk burden, but not necessarily, a disease of huge clinical impact. And though it has significant morbidity, maybe not such a high mortality, what we do see is that there's a significant global burden of bacterial vaginosis, and you can see the prevalence across the globe is fairly similar. Despite the country or the continent that's being represented here in this slide. So it's a pretty significant challenge that we face with the diagnosis of bacterial vaginosis across the globe. And so for vulvovaginal candidiasis, the presentation has significant overlap, as mentioned, with bacterial vaginosis, but there are some unique characteristics with vulvovaginal candidiasis. The presentation is more of a white and thick discharge rather than the thin homogeneous discharge. There's no odor necessarily associated with candidiasis, but the presentation of itching and burning is present. Some important considerations and diagnostic considerations to think about for vulvovaginal candidiasis is that while Candida albicans is the most common Candida species associated with candidiasis, there are non-albicans organisms that are associated with this disease, and the prevalence can range from 5 to 60%, depending on the population and the number of recurrences that are identified. And recurrent vulvovaginal candidiasis, this is usually described as 4 or more episodes of symptomatic candidiasis, vulvovaginal candidiasis within 1 year. And it's been described that non-albicans Candida can be more significantly associated with recurrent VVC that can be seen. And so if we look at this next slide, it shows us this nice depiction of lifetime patterns of vulvovaginal candidiasis, whereas the routine over a lifespan, you can see that an individual may present with multiple episodes, just kind of a routine multiple episodes of Candida over a lifetime. But then there also can be, again, associated with hormonal-related candidiasis. So in this slide, the lighter pink area is the reproductive age, and so you can see that at time periods of pregnancy or time periods of menopause or use of hormone replacement therapies, there can be an increased number of episodes of vulvovaginal candidiasis that would occur related to these hormone-changing events in the life of the patient. Then on the bottom, we see an example of a patient that experiences recurrent vulvovaginal candidiasis. And so we see many more episodes that are much more closely linked. And on the bottom, what you can see is that there are these 4 episodes that are very sequential and very tightly clustered there. And then the use of suppressive therapies to try to diminish the amount of organism, the amount of Candida present in the vaginal space. That suppressive treatment may be stopped at a period, and then once again we may see these episodic recurrences of vulvovaginal candidiasis. And so again, while not necessarily a disease of high mortality, there is significant morbidity and discomfort and loss of productivity that can be associated with these many episodes of Candida in a disease or a condition that affects people fairly significantly. We see on the far right-hand side of the slide that there's an approximate 75% lifetime risk that individuals will have at least multiple episodes of VVC throughout their lifetime. And then finally, for the final pathogen we'll be discussing today as it relates to vaginitis and vaginosis is Trichomonas vaginalis. Again, there is discharge associated. In this case, the discharge is typically green or yellow. There's a foul odor that is described, and then again, vaginal and abdominal pain are described clinically. Interestingly, with Trichomonas, around 80% of infections are asymptomatic, but in symptomatic patients, what we do see is that there is some racial and ethnic disparity associated with Trichomonas, with African American women being affected at a higher rate, around 13% versus non-Hispanic white women. The prevalence of Trichomonas is also higher in women that are over 40 years of age. And to address some of the infectious risks, infected men may be treated to reduce the risk of transmission to female partners. And again, with Trichomonas, as we saw with bacterial vaginosis, we see an increased risk of for HIV acquisition and increased genital shedding of HIV in infected women. Now, there are some overlaps between the treatment of Trichomonas vaginalis and bacterial vaginosis with the use of metronidazole for both of these conditions. So let's just look briefly at the relative abundance of Trichomonas compared to some of the other sexually transmitted infections. So again, this is a global view of sexually transmitted infections in women in the reproductive ages, approximately. And what we can see is that Trichomonas really is a quite prevalent organism that in most cases we see is higher than chlamydia, gonorrhea, and of course syphilis, but really it is one of the most prevalent sexually transmitted infections that is seen in women across the globe. And so really we're talking about a global challenge that we see with Trichomonas vaginalis. And so diagnostics, again, is important to be able to address these issues. And so if we take these organisms together, Trichomonas, bacterial vaginosis, and vulvovaginal candidiasis, again, I think people often may consider these to be lower risk organisms, not associated with a high mortality, but because of the higher prevalence of these organisms and then the combined morbidity that can be associated with some of the sequelae of disease, we find that there is a significant economic burden. And so for Trichomonas, we see the economic burden in the United States being around $19 million. For bacterial vaginosis in the United States, $1.3 billion just for the disease. But then if you look at the associated sequelae of preterm delivery, premature rupture of membranes, additional sexually transmitted infections that could be associated with the acquisition of bacterial vaginosis, we can get up to $4 billion of economic burden in the U.S. For bacterial vaginosis, with an overall global burden that was described of almost 14 billion U.S. dollars. And then for vulvovaginal candidiasis, between both the over-the-counter prescriptions and treatments, along with the loss of productivity, and then diagnostics and physicians, patients seeking care from clinicians, we find about a $14 billion burden for vulvovaginal candidiasis. So again, this is a pretty significant disease state that we see here. And so one of the questions, though, that many people ask is, really, are these laboratory tests for vaginitis necessary? Can't clinicians just make the diagnosis based on the clinical presentation? And so in this study that compared an in-clinic test, a clinician diagnosis, and a laboratory test, what we see is that the in-clinic point-of-care test and just the clinician diagnosis of the clinical criteria, we see sensitivities that don't exceed 80% for BV, and then are even lower than that for Candida and Trichomonas. And so we also see that when multiple pathogens are detected, that the clinician diagnosis is really only about 20%, less than 30%, when there's multiple pathogens that are the cause of vaginitis. And so I think we see that we need to have appropriate diagnostic tests for vaginitis. The challenge is that there are significant symptom overlap between these organisms that cause bacterial vaginitis and vaginosis, BV, Trichomonas, and vulvovaginal candidiasis. But not only that, there's other organisms that can produce similar genitourinary symptoms like Mycoplasma genitalium, chlamydia, gonorrhea, urinary tract infection, HSV. Other organisms, other pathogens have this significant overlap, and that's why good quality diagnostics are really important. And so as we look at the diagnostic methods that we have available for us, physician office testing, the AMSLS criteria is the general physician's office clinical diagnosis that can be made looking at the vaginal pH, the characterization of the discharge, and the release of this odor after the addition of potassium hydroxide to the vaginal fluid. Unfortunately, but to be expected as described in the previous slides, the sensitivities and specificities of these criteria really are fairly low. There's also a point-of-care test that's available for the diagnosis of bacterial vaginosis that actually looks at the vaginal fluid for sialidase activity with, again, fairly low sensitivities on the lowest side. The specificity for BV is decent, but at that low sensitivity, you really run the risk of missing many positive patients. When we look at the laboratory diagnostic methods, we have the Nugent score, wet preparations, and the culture swab for Candida, and then these molecular diagnostic methods that we will discuss. So as the Nugent score that's been mentioned a few times, we look at the presence and score based on a gram stain of the vaginal secretions for gram-positive rods representative of lactobacillus, gram-variable rods representative of Gardnerella, and then these curved gram-negative rods representative of Mobiluncus. And based on the prevalence of the organisms in the gram stain or the quantity of the organism in the gram stain, each of them get a score, and then that score is interpreted as either a normal vaginal flora that would likely be dominated by lactobacillus, an intermediate or positive for bacterial vaginosis. Again, not an excellent sensitivity or specificity that we see for the Nugent score, with the opportunity for both missed diagnosis at this low sensitivity and specificity. For Trichomonas, there are some rapid diagnostic tests that are available, again, with a suboptimal sensitivity, though the specificity performs decently. And then, according to the 2015 CDC treatment guidelines, they now recommend nucleic acid amplification tests for the sensitive and specific diagnosis of Trichomonas, and many of these assays have sensitivities and specificities appropriate for clinical diagnosis exceeding 95%. There's also the combined detection, multiplex detection of the organisms associated with vaginitis and vaginosis that's seen in the BD Affirm assay. It's a DNA probe method that detects the presence of Gardnerella vaginalis as the marker for BV, detects Candida species as a group inclusive of the organisms listed here, and Trichomonas vaginalis. And so with this assay, we have the opportunity to address some of the issues of symptom overlap, with one sample being able to detect all of these organisms in a single specimen using the DNA probe method. One of the challenges, though, that we do face with the BD Affirm is that there's variable sensitivity and specificity based on the target, and in some cases due to the target inclusivity. And so what we see with at least BV, just to point out, is that there is certainly the sensitivity is fairly good in this method, but there are some challenges with specificity that we'll discuss in a few slides. There is some potential loss of sensitivity with Candida, though it can be difficult to determine how much Candida is truly associated with disease versus the amount of Candida that's present just in a normal vaginal tract. And here the sensitivity in this study was shown to be quite low, although this was a relative sensitivity, and there wasn't a very specific reference standard. A gold standard reference was not necessarily used, and so this may not be the most accurate determination of the sensitivity for Trichomonas. However, the sensitivity of this is not as sensitive as a nucleic acid amplification method that's recommended by the CDC. But what this study really did, I think, highlight in a very helpful way is that using a nucleic acid amplification test, you can see what the impact would be in these relative prevalence of organisms. So in high incidence setting, this would be in these higher levels, you see a more higher performing assay gives you a much better accuracy with like a 92% diagnostic accuracy versus a 72% diagnostic accuracy. So looking for diagnostic accuracy is really important in these cases. And so this brings me to what was a fairly recently developed panel by BD, which is the BD Max Vaginal Panel, that uses this algorithmic detection of multiple pathogens associated with bacterial vaginosis, including the identification of lactobacillus along with other organisms to give this algorithmic detection of the vaginal microbiome. And then we have, for the Candidiasis, we have Candida group, which includes Candida albicans along with other organisms, but then separately speciates Candida glabrata and Candida krusei, which are the organisms that are most associated with resistance to routine first-line therapy of fluconazole. And then the DNA nucleic acid amplification detection of Trichomonas. And so we performed a study where we had 200 compliant patients in which we had 4 swabs that were collected to look at the comparison between the BD Max panel and the previously or the current standard of care, which was the BD Affirm assay. In the patients that we had in our study, the symptoms, as we see and expected, were overlapping, with the most common presentation was discharge, followed by itching and odor, but there were significant symptoms that were present. Most patients presented with 2 symptoms, but we had patients who had up to 6 of these symptoms that were present in a single patient. And so we'll start with BV and some of the challenges in the diagnosis of BV. So I have represented here some graphic or visual representation of what a gram stain of vaginal flora might look like. And so this patient would have been a patient who had symptoms of BV in the upper left-hand corner. The Nugent score would be positive. We've got all these gram variable rods, a single curved rod, and not too much lactobacillus, and the Affirm would have called this patient positive. The patient on the lower left-hand corner, patient wouldn't have any symptoms of BV. The Nugent score would be negative, probably no AMSL criteria. We wouldn't have seen any clue cells, and the BD Affirm would have called this patient negative for BV because there was no Gardnerella vaginalis present. But here's the challenge. What happens when you have a patient who does have a lot of Gardnerella vaginalis, but also has a significant amount of lactobacillus? Is this patient negative for BV due to the presence of this protective lactobacillus? Or what about the patient that has some lactobacillus there, but doesn't necessarily have Gardnerella as in high proportion? Maybe there's other organisms that could be associated with BV, so a non-Gardnerella vaginalis cause of bacterial vaginosis. So the question that we wanted to look at is how these various diagnostic presentations would fare using the current standard of care method compared to the BD Max assay. And so in our study, we had 200 patients, 10 we were unable to analyze, and we have this comparison between the BD Max and the BD Affirm assay. So what we see is that while there were 73 tests that were concordant between the 2 assays for positive and 80 tests that were concordant for negative, there were 29 patients who are positive on the BD Affirm but negative on the BD Max. And then when we looked at the Nugent score, what we see is that there were 3 patients who were positive for Nugent, but 19 patients who were negative by the Nugent score, and 7 patients who were intermediate in the Nugent score. Of these patients, these 29 patients who were Affirm positive but negative by the investigational assay, the BD Max, almost all of them, 28 out of 29, were treated for BV, yet at least 19 of these likely did not require BV treatment, and then there were an additional 7 that were indeterminate. Now, when we look at the BD Max samples that were positive by BD Max but negative by the Affirm, we see that there were 3 that were positive by Nugent, 4 that were negative by Nugent, and then 1 that was indeterminate by Nugent. So there's some variability in terms of the reference method for these samples that were positive by the Max but negative by the Affirm. And then only 1 of these patients was treated for BV based on the symptoms that were presented. And so when we look at the diagnostic accuracy for BV, when we compare the Affirm to the BD Max panel, what we see is actually fairly similar sensitivity between both of these, but the specificity of the Affirm is higher at 96.1% compared to 81% seen in the Affirm. And what we kind of predicted is probably the case is that on the right-hand side, the patients with no symptoms for BV, perhaps these patients have a higher presence of lactobacillus, and so it's more protective. And so even on the Nugent score, they're negative, but the Gardnerella vaginalis may be what's signaling the positive on the Affirm. And then in the patients with symptoms of BV, but they're negative by other criteria, it may be these other organisms that the BD Max vaginal panel is detecting that other than Gardnerella that are causing the symptoms of bacterial vaginosis. Now, when we looked at Candida, we know that 70 to 75% of women develop vaginal candidiasis in their lifetime. And in addition, most of the time it's Candida albicans, but Candida glabrata is the most common non-albicans Candida species. And the routine standard of care may not be effective against Candida glabrata. And so while the BD Affirm assay does detect Candida glabrata, it does not differentiate it as the BD Max vaginal panel does. Additionally, there are some differences. The Candida kefir is present in the BD Affirm, but absent from the vaginal panel, while Candida dublinensis is present in the vaginal panel, but absent from the Affirm. So when we looked at our study, we again see that there were about 42 samples that were concordant positive and 125 that were concordant negative. But when there was the BD Max positive, Affirm negative, a significant proportion of these had a positive culture, with 6 having a negative culture. What's interesting with these samples is that if we look at the culture growth of the samples that we see on the BD Max vaginal panel that would have identified as Candida group, there were 52 that the panel identified as Candida group that were Candida albicans, and then we did have 1 detection of Candida dublinensis, and this one is expected to have been missed by the Affirm. But importantly, the BD Max panel detected and differentiated 4 cases of Candida glabrata detected alone, and then 3 additional cases of Candida glabrata detected in the presence of Candida albicans, detected and differentiated in the presence of Candida albicans. So we had an overall prevalence in this study of Candida glabrata of 11.3%, and 6 of these 7 patients were treated with the standard dose of fluconazole, which may not necessarily have been effective against Candida glabrata, though the full patient follow-up has not yet been completed for these patients to see if they continue to present with additional symptoms. So what we see in this study is that we have improved sensitivity for detection of Candida, and that's been confirmed by the reference culture. There is a slight decrease, but not significant in the specificity due to 6 what's been determined as false positive Candida results, but this may be due to the increased detection of Candida as part of as a amplification, molecular amplification test result. In the study, we did look at Trichomonas. We had a very low prevalence in this study with only 8 positive patients, and the results were concordant between the vaginal panel and the Affirm. And so when we look at the patient's prevalence by age, we see in this study the blue line is the age of the patients, and we have a higher proportion of younger patients in this study, and the prevalence of BV by the red line we see occurs in patients from 18 to 50 years old, while Candida we see over the entire span of the patients here. Interestingly, in our study, though we normally expect to see Trichomonas in patients over 40, in this study, likely due to the lower number of patients in the study, we only saw Trichomonas in the younger patient population. And finally, I just wanted to take a quick look at the detection of multiple pathogens. So if we look at BV, BV was seen in combination with all of the other targets that were seen. 49 times patients only had BV, but was also detected in other instances with Candida, Candida glabrata, and actually 7 of the 8 Trichomonas positive specimens were also positive for bacterial vaginosis. Candida group was usually detected by itself or with Candida glabrata, and then Candida glabrata was then, usually it could be detected with Candida group or BV, or it could just be seen alone. And then again, there was just one patient that was positive for Trichomonas in the absence of any other positives. So finally, we can see with the overall performance of the BD Max vaginal panel, if we look at the diagnostic accuracy of the Affirm over these 200 patients, the Affirm in our population had a diagnostic accuracy of 79.2%, while the BD Max molecular panel had a diagnostic accuracy of 93%, with 186 out of 200 patients being appropriately diagnosed based on our reference comparison methods in this study. So in summary, we know that vaginitis is a worldwide challenge with significant economic impact for diagnosis, treatment, and then the associated adverse outcomes as described earlier. We know that the vaginal microbiome is complex, and we need to do a better job of understanding dysbiosis and using our understanding of vaginal dysbiosis for the development and utilization of diagnostic methods. Here I present a study in which we examined the use of the BD Max vaginal panel, and we saw improved specificity for the detection of bacterial vaginosis, improved sensitivity for the detection and differentiation of Candida glabrata. Of note, we didn't have any Candida crucei detected in the study population. And overall, we saw an improvement in the diagnostic accuracy when using the BD Max vaginal panel for the detection of vaginitis. And so with that, I would like to conclude the presentation today and thank the individuals that participated in this study and the recruitment of patients for this study. Thank you very much, and I think we can open up for questions.
Thank you, Dr. Culbreath, for your informative presentation. And yes, it's time to start our live Q&A portion of the webinar. If you have a question you'd like to ask Dr. Culbreath, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. Those questions that we are unable to answer today live and those submitted during the on-demand period will be answered via the email address you provided at the time of registration. So let's get started. Dr. Culbreath, our first question. What is your perspective on how women are being diagnosed with Nugent scoring? Is this a common practice?
I think it is a fairly common practice among laboratories. Our laboratory actually continues to offer Nugent score. And so I think laboratories are offering Nugent score. It is being utilized, but as described, there are some challenges with the sensitivity and specificity of the Nugent score for the diagnosis of bacterial vaginosis, which really brings us to the need of improved diagnostic methods.
Now, what organisms that are not visible in a Nugent score gram stain are important to consider for assessing BV?
Yeah, so there's some other organisms that are actually I think really important, and if on one of the earlier slides, we saw a lot of organisms that are associated with bacterial vaginosis and higher Nugent scores. Many of those organisms are either non-cultivable or not visible, readily visible on the gram stain. So this includes organisms like Megasphaera, organisms like bacterial vaginosis associated bacteria 1 and 2, and multiple other organisms that are either not visible or not counted in the Nugent score criteria. And so this is where the utilization of molecular methods can really enhance our ability to detect and diagnose bacterial vaginosis when the scoring criteria is either unavailable for these organisms that are more difficult to see in the Nugent score, or adding in then all of these different morphologies would just make a gram stain scoring method so complicated that I think it becomes no longer viable for laboratories to perform. Even now, the Nugent score, though fairly prevalent, is still a pretty complicated challenge for laboratories to be able to execute in a timely manner with the volume of tests that many facilities see.
Thank you, Dr. Culbreath. Now our next question. Does the BD Max test report give the result of each target by name, or does it use an algorithm to report as positive or negative for BV?
It's an algorithm, and so it is reported as the flora is either consistent or inconsistent with bacterial vaginosis, but it does not name the specific targets that are positive in the bacterial vaginosis call. It does for Candida. It will differentiate Candida group versus Candida glabrata versus Candida krusei, but it does not go through each of those organisms for bacterial vaginosis.
What is the liability of using a non-FDA approved assay?
There are guidelines that are given by regulatory bodies for how laboratories should validate and implement non-FDA cleared assays. I would point out that both the BD Max Vaginal Panel and the BD Affirm are both FDA cleared assays. But if a laboratory was using a non-FDA cleared assay, there are guidelines for how laboratories could implement those methods.
Thank you, Dr. Culbreath. Our next question. For BV particularly, how important is it to know the presence or absence of specific BV-related organisms? And would knowing these be clinically relevant, and in turn, would it impact therapy decisions?
Yeah, so that's an interesting question. I think to know the species of organisms is probably not as relevant because many of the therapies have not necessarily been organism specific. It's been more condition related. But what I do think is important to point out is that knowing or having a method that takes into account the entire community of organisms that are present, which is basically what the Nugent score does. It takes into account the entire community. I think having a molecular method that takes into account the entire community to then give a result is important, because different from many of the other diagnostic or the disease states that we examine, bacterial vaginosis is not just the presence or absence of a single pathogen or target. It is a dysbiosis, or a change in the global community. So I think single organism identification is really not as important as an understanding of what's happening in the community of the vaginal space.
Our next question, relative to the comparative study you performed in your lab, can you speak a little to the speciating of glabrata and cruce and how this capability with the BD Max vaginal panel resonated with the physician providers?
Yeah, I think that's a great question. Thank you. I think first, there were a lot of questions with providers, really, and I think the question would be for many of the providers would be how, what are they supposed to do with Candida glabrata? For many providers, regardless of the method that was used in the past, maybe with the exception of culture, they would not have ever known that the Candida species was Candida glabrata. And so through this study, the study was not prospective, it was retrospective, and so the results were not provided back to the clinical providers. But I think it begins to give opportunity, one, to recognize the prevalence of Candida glabrata, and then two, to really understand better if different treatments are required for vulvovaginal candidiasis associated with Candida glabrata. Perhaps it may not necessarily change initial therapy that would be given in the provider's office before the result is generated by the laboratory, but perhaps it would impact follow-up therapy after recurrence, and perhaps some of these recurrent infections are due to suboptimal therapy of a fluconazole-resistant organism like Candida glabrata or Candida krusei when it's treated with the routine standard of care, fluconazole, over multiple episodes. So I think long-term we may be able to see an impact of being able to speciate Candida glabrata through other studies looking at the prospective use of assays that do that type of differentiation.
Thank you, Dr. Culbreath. And we have time for just a few more questions. Aerobic vaginitis is a recently recognized vaginitis. Did you think or look into some of your patients that did not fit the diagnosis of BV, DVC, or Trich?
Thank you for that question. Aerobic vaginitis definitely is an emerging entity. Definitely poses some challenges in diagnostics, as many of the organisms that are usually associated with aerobic vaginitis can be part of the normal vaginal or GU flora. And so we did not specifically look at aerobic vaginitis as a potential cause of bacterial vaginosis or vaginal discomfort in this study. And I think it still remains an area that requires additional investigation into the appropriate diagnostic methods for aerobic vaginitis.
Thank you. Next one, are we overtreating BV? And can BV clear itself without metrodiazole? What are your thoughts on using boric acid suppositories?
Okay. So this is quite a clinical question, but I would say that based on our study and others, one challenge is to the diagnosis of BV because we have lacked sensitive and specific methods, when you lack specificity, that results in more false positive results being detected. And so we saw that potentially with the standard of care reference that was used in our study compared to the BD Max. So the standard of care lacked specificity, and so it was calling more positives than were truly seen clinically. And we saw that with other assays. And so I think by having a more specific diagnostic test, you reduce the number of false positives, thereby having more specific results. And I think that might then address some of the issues of overtreatment.
Okay, now we're almost out of time. Let's just see if we can. I know there are several questions in here that we haven't got to, and I know more will be coming in. Let's go ahead and save these questions to answer via email. And Dr. Culbreath, do you have any final comments for our audience?
No, thank you for your time and attention, and there were great questions. So thank you very much.
Thank you again. And we want to thank our audience for their great questions today. And we also want to thank LabRoots and our sponsor, BD, for sponsoring today's webinar. Now, I just want to remind our audience, for those questions that we did not answer, they will be answered via email following the presentation. This webinar can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. A quick survey will now pop up on your screen, and we appreciate your participation as it does help improve our webinar program. Thanks for joining us today, and we hope to see you again soon.